Good afternoon, everyone. Thank you for braving the rain and the lovely Boston weather, and welcome to this American College of Surgeons Healthcare Forum emphasizing quality. This is part of a national tour of sorts that the college is doing to try to bring this message of quality to all of you and to everyone else. I don't really have to introduce myself, but I used to be Surgeon-in-Chief at the Massachusetts General Hospital, and I am W. Gerald Austin, Distinguished Professor of Surgery at Harvard Medical School. But perhaps more pertinent to this particular meeting, I chair the Health Policy and Advocacy Group for the American College of Surgeons. I'm really pleased to be co-hosting this forum today with my colleague, Dr. Michael Zinner.
And good afternoon, too. I'm Mike Zinner. I'm Chief of Surgery at the Brigham and Women's Hospital and the Dana-Farber. And as it applies to this meeting, I'm also fortunate to be a regent of the American College of Surgeons. Andy and I are really pleased to be here, to be able to chat with you, to have a dialogue with you about issues surrounding quality and health care. We've been in this business our entire professional career, and it's because of that that we care so deeply about the things that we're going to be talking about today, so that we can continue to develop young people and that we can continue to develop the field as we see. We also know that things have to change, the least of which is things that were going on in this state. The things that need to change, though, we're not exactly sure what they're going to be. We're not exactly sure how easy it's going to be, but we do know one thing, and one of the things we'll try to get across this afternoon is we have some concrete ideas about how those changes may take place and how we can affect them. With this, we think we can develop higher quality, higher value, and because of those two, be able to develop even better access. This is why the American College of Surgeons and the Massachusetts chapter of the American College of Surgeons are conducting this forum, and as Andy said, this is one of several forums we're conducting nationwide. All of the forums have the theme of inspiring quality, highest standards, better outcomes. We believe that if physicians and surgeons and hospitals are better engaged in these important dialogues, then we're going to improve all of the aspects of care, quality, access, and cost. Our intention in conducting these forums is to spur discussion about what we in the medical profession do. And in our case, we'd like to make things better, to use a term from Dr. Gawande's second book, better. In fact, we're doing a lot. We know we can do more, and we hope that out of today, we'll be able to share some of the ideas into things that we can apply directly to our hospitals. Today's remarks will focus on the value proposition, that quality surgery not only delivers better patient outcome, but also delivers better financial outcome. You'll hear many of today's speakers refer to a growing body of evidence that shows that appropriate quality care delivered the first time lowers cost. It is a common sense, of course, in the fact that we understand that preventable complications would decrease costs, we'd lower lengths of stay, we'd decrease readmissions, but that hasn't been a widely accepted notion in the healthcare policy world. Why is it important? Because surgical care makes up half of the annual healthcare expenditures for inpatients nationwide. Now that's among commercial payers, but it's reflected also in the government payers. The simple fact is that improving surgical quality is a critical and often overlooked tool in improving healthcare outcomes and cost. Our college, the American College of Surgeons, sees things differently, though. Not only does the college see improving quality as fundamental to who we are, and you'll hear that in Dr. Warshaw's presentation, but we also believe that quality improvement is instrumental to improving healthcare systems, including value, costs, and eventually appropriate care. But we also know that we need to articulate this to a larger national audience. With this in mind, you will hear from one of our keynote speaker, Stuart Altman, that over the years of national debates on healthcare reform, most of the discussion has centered around access and cost, leaving quality almost out of the discussion until recently. Our message today is that we truly are trying to deliver value and reduce costs, and we must make sure that these quality improvements translate into those achievable goals. Boston's place among our country's healthcare leaders is reflected by what you're going to see in this impressive panel of speakers we have today. Each of them will bring their own perspective to the challenges and opportunities of quality improvement. Andy's going to provide an overview of the American College of Surgeons' Inspiring Quality Initiative, and then we'll move into introducing our keynote speaker in the panel. At the end of the brief presentations, we have reserved about 30 minutes for audience questions and answers. Please think about those as we go along and hold them till the end. And when you do, there'll be microphones available, and we ask you that you please identify yourself. Dr. Warshaw?
Thanks, Mike. Surgical quality obviously matters everywhere in this country, but we have special pride here in Boston because this is where Ernest Amory Codman, more than 100 years ago, founded the quality movement. He made his stand on the imperative of quality improvement as a critical component of the profession. As Mike alluded to, the title of these forums is Inspiring Quality in Surgical Healthcare, quality improvement programs that improve outcomes and reduce costs, and that, of course, is what is on many people's minds today. The theme is intrinsic to where the American College of Surgeons is today. It's not just the college, but these are themes that are shared broadly across a number of the institutions that determine our healthcare. It's highly consistent with the National Strategy for Quality Improvement in Healthcare, which is driven by the U.S. Department of Health and Human Services. It's highly consistent with CMS and the triple aim that was articulated by Donald Berwick, which says that improving the U.S. healthcare system requires simultaneous pursuit of these three aims: improving the experience of care, improving the health of populations, and reducing the per capita costs of that care. And the learning healthcare system, which has been promulgated by the Institute of Medicine. Quality is a shared interest, and it's a mission that feels like at this time the stars are finally aligned for quality improvement, with everybody chipping in. We believe it's critical to seize this opportunity to advance the quality agenda. I would point out to you that the American College of Surgeons has been in this game for more than 100 years. We're celebrating our 100th birthday this year in 2013, but over the course of that 100 years, there have been many ventures that have started with the college. It began with the minimum standards for hospitals in the teens of the last century. That program evolved into the Joint Commission ultimately, and incidentally was again engendered by the work of Ernest Amory Codman. There have been a series of, and this all has culminated in the NSQIP, about which I'll speak a little bit further. But as you can see from this slide, there are many other aspects of data gathering, data management, and quality improvement that have come out of the Commission on Cancer, the Committee on Trauma, the American College of Surgeons Oncology Group, and others that the college has promulgated over the years. This is not new for the American College of Surgeons. Codman started in about 1905 to develop the idea of end results, that which we call outcomes right now. That, as I said, led to the foundation of the American College of Surgeons, the Hospital Standardization Program, and then ultimately the Joint Commission. The story about Codman is kind of interesting for those who may not be familiar with it, because he was I would say, a lot ahead of his time. And in trying to get the senior physicians of the Massachusetts General Hospital to accept this concept that you don't simply take care of the patient, shove them out the front door, and not follow up, he felt that you ought to know what the end results or outcomes were. It didn't quite go over with the senior physicians at the MGH, and in fact, the times got so difficult that Codman felt he had to resign, and did, from his position, and started his own hospital called the End Results Hospital on Beacon Hill. Eventually, this became so frustrating, this whole effort became so frustrating, that he actually burned all his files. Nonetheless, the idea has lasted. He said at the time that it would probably take 100 years for appreciation of these efforts to really come to fruition, and I think we're seeing that now, just about 100 years after Codman. And so it's particularly appropriate, I think, that one of our speakers tonight, Matt Hutter, is the director of the Codman Center at the Mass General, recognizing those efforts, maybe 100 years too late, but at least now. Dr. Codman is credited with saying, "So I'm called eccentric for saying in public that hospitals, if they wish to be sure of improvement, must find out what their results are, must analyze those results to find their strong and weak points, must compare their results with those of other hospitals, must welcome publicity, public reporting, not only for those successes, but for their errors, because if you don't, you can't fix them." And he said such opinions will not be eccentric a few years hence. Well, it took 100 years, but it's, basically he was right. This cartoon is one that Codman himself drew around the time that he was fighting with the senior physicians and board at the MGH, and basically the depiction is of the ostrich bearing its head. If I don't look and see, then basically, nobody will know is the concept. Due to his influence, Codman really led to this kind of structure of what one must do to ensure quality. First of all, you've got to have standards, and the standards include objective standards that are backed by research, that have been verified, that are clinically driven based on what really happens with patients, not just process, and that will allow the providers to choose the right care at the right time in the right setting based on individual patients' unique characteristics. Secondly, you have to have the right infrastructure. That includes the articulation of appropriate structures, knowing what you need in terms of staffing levels, number and type of specialists, appropriate equipment, and I think part of the theme today is the infrastructure for measuring outcomes, for knowing what you are doing. That doesn't come easily, but it must be done. The data has to be clinically driven. It has to be based on medical charts. It has to be based on the appropriate research, on post-discharge tracking, a la Codman, and must be continuously updated because medical care changes, the needs change. And I would add to this that the data has to be risk adjusted. That's a lesson that the NSQIP, again, the National Surgical Quality Improvement Program, has really brought to fruition. You can no longer say, my patients are sicker than your patients, so it doesn't count. And then there needs to be verification. It needs to be, external peer review so that if there's a problem, it can be fixed. You need to know how you stand. Not everybody's perfect. The expectation of perfection is unreasonable, but you need to know in a given situation, in a risk-adjusted situation, how you perform in comparison with your peer hospitals and peers across the country, and you need to say that out loud so that people really know and can both either appreciate or fix. So effective quality improvement measures outcomes improvements. And the poster child, as far as I'm concerned, is the National Surgical Quality Improvement Project of the college. This is, as I said, risk-adjusted. It's based on clinical data and on robust clinical data. It has a proven track record at this point. That hospitals which focus on quality improvement can prevent complications and disparities in care. Now, preventing complications, I think Dr. Zinner mentioned before, and I think we'll hear over and over, that it's a good thing when complications are prevented. It's good for patients, but it also lowers costs. And a 2009 study in the Annals of Surgery showed in the 118 hospitals that were included in this study group, they were the ones that began participating in NSQIP in 2005, and it's really quite remarkable. That study showed that participation and adherence to the NSQIP prevented 250 to 500 complications annually per hospital. It saved 12 to 36 lives annually per hospital and reduced costs by millions of dollars annually. The statistics on the right side of this slide are dramatic. 82% of hospitals decreased complications, 66% decreased mortality, and as I said, 250 to 500 complications fewer per hospital per year. Does it matter? We talked about lowering costs. If the average cost of a complication is something over $11,000, and I've seen numbers going up to $25,000, and some obviously are more than that, the average savings per hospital per year amount to $3 to almost $6 million per year. And the average yearly savings across, if all the hospitals in the U.S. participated, would be as high as probably $25 billion. Gets to be real money. And the estimated total savings over a decade, 130 to 260 billion, pays for an awful lot of the health care that we would like to provide. So this then is the mantra. We have found common ground. I particularly like this cartoon, that the overlap between lower costs and higher quality care is provided by the NSQIP. There is a video that we would like to show you. It's very brief. It moves very fast. You can't blink. It's like going through a small town. If you blink, you've passed it. But it is really, I think, I've seen it many times. I enjoy seeing it every time. So could we please start that? So just think, this is only about surgery and surgical complications. Just think if these same principles were applied across all areas of healthcare in this country. You each have a little gift, I think, at your tables, and it lays out those 4 principles. It's good for strengthening your hands if you want to take it home and squeeze it, but mainly take it home and remember it. Thanks. Mike?
God, after seeing the video, it makes you want to join something. If the Army's not available, it ought to be the college. When I see the data, and I've worked with programs like NSQIP for a very long time, there's no question to me that these kind of programs play an important role in all of our healthcare and in some of the healthcare solutions. I do have a different set of questions that are going to lead into our keynote speaker. How do we as surgeons and medical leaders work more effectively with other healthcare and hospital leaders and other interested parties to find better ways to share this vision of better quality, better care for our patients? How do we apply our quality programs to achieve these goals by expanding access to healthcare while still worrying and controlling cost? When we set up this forum several months ago, we'd anticipated that a number of the legislators from our state would be able to be here. I am very grateful for the leadership of our region for being here. We have representatives from hospital leadership, we have representatives from physician group leaders, and of course we have a number of surgeons that many of us know personally. But what we didn't plan on was that the state legislature was going to be holding hearings this week, on the proposed healthcare legislation that's coming in Massachusetts. So we'd like to have had more here, but we're really pleased that you all came. Our interest in this is one of the main reasons that I'm so personally happy and grateful to have Dr. Stuart Altman as our keynote speaker. In addition to Stuart being a friend, he's been a key advisor to President Obama throughout the recent healthcare reform efforts. He spent his career on issues related to healthcare, particularly those related to access and cost. While there may be varying degrees of consent or agreement or disagreement over the federal healthcare reform, I think most of us would agree that having people like Stuart, having people informed about what we do is very important. It's the same for our elected officials and their staff. We'd like to make sure that they do, in fact, have knowledge of where we stand and what we do. What we represent in the college and surgeons is that very important component that we deal with, as I mentioned earlier, about cost. If we represent half of what inpatient costs are, then we think we can help lower those costs by doing appropriate things, appropriate actions, and also improving quality. And while we can't quite say this yet, I do believe that where we'd like to go with this is the holy grail of appropriate care. That's going to be based on data and science, and we're going to be able to do that with programs like we have with the NSQIP. How can we use science and data to enable more meaningful discussions with patients so that they have more actionable information? We'd like to be able to say these are the risks and these are the complications, and we have data to show that. And the patients can then therefore make a more intelligent and informed decision. And as we know, when patients get more involved in their own health care, their expectations are more appropriate as well as more grateful for the kind of care they get. We haven't quite been able to deliver that yet with NSQIP, but that's one of the directions we're going. These are some of the discussions we've been having with people like Stuart, and when I approached Stuart and asked him to be a speaker here today, he said, I'm happy to discuss access, I'm happy to discuss cost, but I'm not the quality guy. You surgeons, you're the quality guys. Now, as surgeons, I took that as a compliment. Thank you, Stuart. But truth be known, Stuart was really being a bit modest. He's now a professor at Brandeis, former dean at Brandeis. He's one of the most preeminent healthcare economists and policy experts of our time. He's been involved in or a close observer to every major attempt to reform healthcare policy since President Nixon 40 years ago. In his recent book, I happen to have it here, Power, Politics, and Universal Healthcare, The Inside Story of a Century-Long Battle, by the way, available at Amazon, $17.95, Stewart tells a detailed story about various attempts to reform healthcare from the Nixon administration through the Clinton administration to our recent past legislation. It's a great book, and I really encourage all of you to see it or read it. Whether or not you agree with the Affordable Care Act, Stewart offers insightful explanation about how we got to where we are and what mistakes have been made in the past. And that some of the mistakes made in the past are trying to be all-encompassing in healthcare reform. But by riveting down on that one area of access, we were able, the legislature was able to pass meaningful healthcare reform. He argues that the reasons for that is because we did focus in that area. But frankly, what I found very interesting about reading his book was at the end. At the end of the book, Dr. Altman admonishes us by saying, ignore the cost issue at your own peril. If you do, healthcare reform and the access that was the focal point of it will fail to materialize. And we think we definitely agree. With that, I'd like to invite Dr. Altman up to the podium.
I'm going to stand here. I have a way of disappearing when I stand behind these things, unless they're very low. Second thing, I want to make it very clear, I do own a tie, but I decided that in order to separate me from all the real doctors, I would not have a tie on. But I really want to be very much supportive, as much as I possibly can, in the whole presentation and in the outlook of improving quality as a way of improving costs. The issues I want to talk about today is whether that's enough, and whether we're at a stage in our life and in a stage of our life in our country where the pressure for controlling costs is going to be so great that we're all going to get swamped. Maybe it's a terrible analogy, but providing high quality care in a MASH unit gets sort of difficult. And if we don't watch ourselves, I mean, the level of cost containment that people are talking about, that's where we could wind up. But I do want to talk about it in the context of the recent discussions about accountable care organizations and bundled payments and why we need to do that, and whether this is really a fairly dramatic time. Now, I've been in this, as Mike pointed out, for a very long time. I mean, I started really in healthcare policy in the early 70s when we were spending an incredible amount of money, 7.5% of our GDP and $75 billion. And I was brought to the White House, and the president looked, the president's men, not the president, chairman of the Council of Economic Advisors, and said to me, if we eat 8% of GDP, our whole way of life is going to deteriorate, and your job is going to be to make sure that doesn't happen. So there I was, 32 years old, responsible for controlling healthcare costs. And I hope you're more successful in life than I am, because I'm a blooming failure. Where are we today? For those of you who don't know, we're at 17.5. I'm close at 18%. We're close to $2.6, $2.8 trillion. So the two things I come away with it, I don't know where the tipping point is. I don't know. You know, people ask me, oh, this is unsustainable. I said, yeah, so was 7.5%. So I don't know where that is, but I would not be so sort of blasé about it. It is serious. And I just want to show you some numbers. I mean, I don't have time to go into any detail. This is the percentage of our GDP that goes to our safety net. And we make a big deal about Social Security. The reality is Social Security is a minor issue by itself. Yes, we're going to grow from around 4% to 6% if that was our problem. Our problem is when you start adding Medicare and then, oh, by the way, Medicaid. Now we're talking, and this is a percentage of our gross domestic product. This is our total income, and it assumes a growth that is larger than we're now sustaining. So we're talking about a very rapid growth between 2010 and 2030. And the ability to sustain that safety net is really in doubt. Another way to look at it is that trust fund that supports the hospitals in America. And there is no hospital in America that can ignore Medicare these days. I mean, you know, regardless of whether we talk about the Accountable Care Act, in a way, I'm not saying that's trivial, but compared to the Medicare program, it's going to be trivial. And that trust fund that underwrites the Medicare program is scheduled to go broke originally in 2024. The Accountable Care Act knocked that down, or about 2017. So, by the way, if we sort of allow the Accountable Care Act to go away because it's too costly and all that stuff, that trust fund is going to go back to really full, and we're going to be in some trouble. Back to 2017 if we end the reform. I mean, we can just see it. You don't need to spend any time. Look at the mess we're in with the SGR. I mean, it was, I hate to say it, it was some of my better friends that created the SGR because they, you know, he's sitting around a table and someone said, well, physician income, should that go by more than the growth in our economy? And everyone said, no, that sounds reasonable. I mean, that's not unreasonable. Is that unreasonable? And everyone said, raise a hand. Of course, there were no physicians in the room. And they said, fine, well, let's just do it. And they put it in there, and it sort of snuck in the 1997 Balanced Budget Act. Well, we can't deal with it. I mean, now we're talking about cuts here in this state of GDP minus 2%. We can't even do GDP. So, and by the way, I don't think we're going to solve it so quickly. We've been trying, and my view is we're never going to solve it. So I think it just gives you some indication. By the way, if you look at the growth rates that are projected in Medicare spending, look at that 2012 to 2021. We're talking about growth rates of minus 0.4% in excess of GDP. So the pressure is very real, and it is not going away. Look, I've spent half my life or more in government. The simplest thing for government to do is to cut fees, to cut the prices we pay hospitals, to cut the fees we pay you, whatever it is. It doesn't take very much imagination to draw a line and say it's 10% less than it was last year. It is the worst way. Now, there is a provision in the ACA, these IPAB, these independent, so people said, well, we're not going to do that. It doesn't matter. We can come up with an acronym to do it. The issue is we need to avoid this. It is the worst way to control costs. What you're talking about is the right way. Improve quality, do the right thing, and lower spending and lower costs. This is the wrong way, but this is the simple way that government can do it. I'm a big fan of Michael Lewis. He's a great writer, almost as good as Atul, but he's pretty good. And he comes up with these great lines. He wrote a book called The New Thing, you know, Silicon Valley. So the question I ask us all is, are ACOs and bundled payments the new thing? But before you answer that, what happened to the old new things? What about health planning, certificate of need, PSROs? Go down the list. Every one of them, unfortunately, I lived through them all. When they came out, they were the thing that was going to solve our cost problem. We were going to do the right thing. We were going to control costs. And at the end of the day, they all failed. Why? Were they all bad ideas? No, they were not all bad ideas. So why did they fail? Well, let's just take a look at a few. Let's take a look at two, DRGs and managed care. Two old new things. Let's look at DRGs. Great idea. Works well in terms of funding, but it had only limited success. We had great expectations that hospital costs were going to come down, you guys were going to figure it all out, everything was going to be done right, and it worked. But it only included inpatient care. The idea was DRGs for hospitals today, tomorrow DRGs for physician care. We never got to stage 2. And so we were just paying with one piece of the apple. Important as it is, inpatient services are not enough. We need to combine that with the physician services, and more importantly, we need to talk about after. I'm going to show you some numbers that blow your mind. Many people, and I suspect many of you, don't realize that in many cases, the patients that you treat spend more money after they leave the hospital than they spent while they were in the hospital. What about managed care? Well, some said exceed too well. Managed care did exactly what we asked it to do. We asked it to slow down and control healthcare costs, and we hated it. We collectively in America. And of course, it was destroyed by the 4 Ps. First, it was the provider community. Didn't like the idea that we're being second-guessed by everybody and stuff like that. And then you convinced the patients that somehow they were getting poor quality care, that we were not controlling managing care, we were managing costs. You then convinced the press, which didn't take a lot. We had movies and all that. And finally, we had the politicians, and managed care was dead. And you say, well, good, I'm glad it's gone. Well, the reality is what came after it was not a good thing in a lot of ways. We had the last decade, where healthcare costs grew faster than it's ever grown in our history. So here's the key. What at the end of the day in managed care, more and more as patients and you as physicians became convinced that we were sacrificing quality to save money. Not the right agenda. And what made it worse, to the extent that there were savings, the patients felt it was being shared by the big mean insurance companies and their employers. And that they were not, as patients, getting decent quality care. Now, we have a real opportunity, I hope, through the ACO and bundle payments to offer opportunities. They offer the possibility of integrating care, bringing together less expensive care when it's the appropriate way to do it. Reducing, and this needs to be discussed. Yes, you need to be providing quality, reducing infections, getting the right thing. But the point is that there is a lot of care that's being given today when it's a question of whether it ever needed to be given at all. You're in a much better position to judge that than I am. But we have enough evidence by your colleagues to tell us that 30 to 40% of the care that we're getting either doesn't need to be given at all or can be given in a very different setting. The other thing that, again, you're in a much better position to tell, the amount of stockpiling of every whatsy-dutsy. I mean, I keep hearing these stories, and I don't want to tell your life. You know it. You're the ones that live in that world. I don't know the answer, but I keep hearing the fact that everybody has their preferred hip and their preferred valve and their preferred this. It adds up to a lot of money. The question is, do we need to do all that? What's critically important, and again, I'm talking to you. You live this life, but I just have been around long enough to pick up the tidbits. The fact is that the hospitals and the physicians and the various groups of physicians are not on the same page all the time. Not a way to run a railroad at the end. And what's even worse is when we combine pre-hospital care, hospital care, post-hospital care, you're not talking to each other. That needs to change. So, how are we going to do this? Well, let's talk about it. Now, the big bugaboo, the big discussion with ACOs, these accountable care, broad things, capitated rates and stuff, it turns out that they're not so easy to do. There are some institutions in this country that are ready to do it. And we have a few here in Massachusetts. But you can count them literally on one hand or maybe 2 fingers on the next one. This is not something for the faint of heart. It requires a total integration across sites. The other thing, and let's face it, this is being pushed pretty actively by what I would call the primary care group, who believe that basically what their goal in life is, and believe that it's the right thing to do, is to keep as many patients as they can out of the hands of specialists, and if possible, out of the hands of hospitals, and if really possible, out of the hands of our big teaching hospitals. That somehow you're not the solution, you're the problem. I happen to believe that's a big mistake. I want you on my side. I want you on the countryside. I don't want you on the other side. So, but this is the battle that is taking place. It's easy for you to sit there and talk to each other, but the reality is there is a significant amount, not only of the policy community, the medical community, that views you as the problem. That's why I'm so pleased about this discussion you're having. And the fact that, and I like that tagline, the idea that, now we're going to make a difference. You're not going to be part of the problem. You're definitely going to be part of the solution. But I think the way to do it is to look not so much at ACOs, but at this less complicated of what we call bundle payments. It allows providers to move ahead more incrementally. Rather than trying to integrate all of the care of all of the patients, including all of the people out there that you don't even know who they are, is to focus on the things you do and the things you do well. And it's going to be based increasingly on clinical guidelines that you establish, that are not established by the likes of me. Or forget about me, it's the new 32-year-olds. I'm not going to do it. I need you too much. It's the 32-year-olds that are going to establish. So you don't want that. Patients are critical. You need to focus on them. You can't ignore them. And it requires the participation of specialists, surgeons, but all the specialists. You are American healthcare. And, you know, I get into trouble now with the primary care people because I said, I love you. You know, you're wonderful. But you're not the American healthcare system. We need, everybody needs to play. It's not us versus them. And critically, we need to change the payment system to encourage you to do the right thing, to improve efficiency and coordinate across sites. So what's the difference between DRGs and bundled payments? As I said, DRGs were only for inpatient, where bundled payments starts with the DRG. You need a DRG in order to get into it, but it includes physician services, post-acute care, rehab, physician services, home health, and so on. Look at this. I'm just going to show you this. These are the total amount of money, and the red represents the amount of money in post-acute as you go down the different DRGs. You know, like heart failure. Of the $15,000, 3/4 of the money is outside the hospital. Renal failure, same thing, all of them. You need to, you cannot by yourselves solve this problem, but you sure can be part of the solution. Look at this. When you compare the difference between the high and the low, in total episode, there's a difference of 42%. Physician services, fairly small. That's not where the issues are. It's only about 6.9%. Readmissions, the fact that so many patients come back into the hospital after they've had their procedure, almost 170% difference between the high and the low. Post-acute care, 142, and so on. There is huge differences going on in what is supposed to be science. So, how do we focus on that? On bundled payments, on high volume. The other thing to worry about, for those of you who are in institutions thinking about it, and I don't need for the big institutions, this isn't an issue, but for the medium-sized and small ones, focus on the areas that you do the most of, because you got to get that variation down. And look at this, if you look at that chart, as you look down the number of procedures that a hospital does, you see how the variation falls. So if you're in a small to medium-sized institution, which few of you are, but when we go out into the country, it's true. They want to get into the bundled payment business, and they're sitting there doing far fewer number of cases. Not a smart move to make. So let me finish by talking about the big picture. How do we move forward in an aggressive way, but in a way that has some understanding of the future? How do we do this in a way that allows you time to make this work? How do we avoid the errors of the past? So what are they? In the past, and let's take managed care, all of a sudden, overnight, we went to the medical community and they said, you are responsible for a whole class of patients that you have, and oh, by the way, not only your patients, but the people out in the community, and you have to take risk. And you know, let's face it, we don't pick the meek at heart and we call them physicians. Physicians said, oh, I can do that kind of stuff. Sure, I can develop. Well, you didn't know what you were doing. The people that did it had, and it wasn't that you were stupid, it's you didn't have the data. And so we asked physicians and hospitals to take risks in the 1990s. And of course they couldn't, they didn't know what they were doing, and they wound up losing a lot of money. From the patient's perspective, I learned the history of the Kaiser plan. And Sidney Garfield, when he created the Kaiser plan, he said, Kaiser is not for everybody. I want to make sure that the people that are in my plan, in my organization, want to be there. I don't want anybody forced into capitation and managed care. So everyone has a choice. Well, what happened in the 90s We forced millions of Americans into managed care, and I don't have time to explain why we did it. It's like, you know, having a club where 80% of the people didn't want to be there. Didn't take long for the people not to want to be in that club, and so they began to change it. Most importantly, as I said before, managed care became managed cost. Why? Because we had no quality measures, so the only way we could measure it really was by costs. Not a good thing. Now, when it comes to bundled payments, again, as I mentioned, the DRG is only focused on the inpatient. Not enough. You need to get you as physicians into the act, and you need to get post-acute. Ideally, we need to go to pre-acute as well. So, how can we avoid that? We're going to move forward to avoid those problems. First of all, we're going to ask most hospitals and doctors to include not only the inpatient, but to include physician and post-acute care. Again, this is a tricky area, and a lot of my friends in the provider community, including myself, believe that you should have patients in the game, and they shouldn't be allowed to bop in and out of different systems. But in the short run, we need to do it a little more slowly. We can't say to patients, you have to be in this group. Once you sign in blood, you cannot leave. It creates such hard feelings. So patients are not going to be required to be a provider. If they want to leave a group, they can. And non-Medicare payers are being encouraged to be part of it. And most importantly, the definition of how you get paid is going to be measured as much by the quality. It is not going to be a cost game alone. It's going to be both sides of that circle. So where do we go from here? Key, and that's why I look at the bundle payments. It focuses on appropriate care, improved outcomes, as you said, lower costs. Not only is it doing the right thing when you're there, but you need to be part of the solution to get costs within your institutions down. And it needs to be better for the patient. Obviously, as a patient, I want the best quality. I don't want mistakes. I don't want errors. So the patient needs to feel that you're on their side. Outcomes are critical. And it builds into where your philosophy is. For us to go at you, which we did in the past, and maybe I was responsible for it, I hate to say it, but we dismissed too easily the role of the physicians. We didn't think you were important. No, it wasn't that. We thought you were part of the problem, and therefore we didn't want you into the solution. Big mistake. We need you as part of the solution. Not that you're going to dictate this. You cannot. There are too many $2.6 trillion feeds too many mouths. You are not alone in this, but you need to be part of the solution. So the question is this enough by itself to lower costs and improve value? No. I'm sorry. It is not enough. But it is a great start. And again, Mike, thank you for inviting me. You're really on the right track. Thank you so much.
Thank you, Dr. Altman. And I would, this is absolutely on target. I would particularly like to emphasize the fact that the difference between the 1990s and now is hopefully that the patients are going to realize that we're on their side. It isn't just taking something away from them, but in fact giving them something better.
Stuart, thank you. You were right on target. And as I think many of you can see, he's on the serious side. He's a very knowledgeable expert in healthcare. But for those of us who are also on the healthcare quality side, or on the healthcare economics and policy side, Stuart is known as the Woody Allen of healthcare policy. And it's very clear that you also can deliver a great line and you have a great sense of humor. So thanks for being here, Stuart. Let's introduce our panelists.
So in the interest of time, we're not going to go through the very impressive bios of our esteemed panel. That information is in your program if you need it. But rather than going through that, we're going to ask the panelists to come up here now, all of you, and to share with you their work in brief statements. They were 5 minutes and 5 minutes each, and then we will have enough time for questions which we would like to invite from the audience. At the conclusion of all of their talks, we'll open this up for discussion. So our four panelists, Dr. Matthew Hutter, on your left, is the director of the Codman Center for Clinical Effectiveness in Surgery at the Massachusetts General Hospital. Again, particularly appropriate in remembering Dr. Codman. And then next to Dr. Altman is Dr. Peter Slavin, who is the CEO and president of the Massachusetts General Hospital.
Next to Matt is Sam Finlayson. Sam is the director of the Center for Surgery and Public Health. That's a joint effort between the Harvard School of Public Health and the Harvard Medical School. He's recently joined us from Dartmouth with national experience in healthcare health services research. Next to him is Atul Gawande, who is an active surgeon at the Brigham doing endocrine surgery, as well as taking night call and doing what we affectionately know as dead bow in the middle of the night. But he's also a national and internationally recognized author in the area of quality and safety.
Dr. Hutter, I think you're leading off.
Thank you very much. I'm going to speak a little bit about quality improvement at the local level, being inspired by Dr. Altman's talk just recently. But really the focus has been on inspiring quality locally and improving the quality of surgical care at our hospital is what I've been focusing on. The key aspect to that is measuring it. Having quality metrics of data that you trust, data that reflects the care being given, high quality data. High quality data is risk adjusted, it's prospective, has standardized definition so that a urinary tract infection at Mass General Hospital is the same as a UTI in North Dakota. Having that kind of information is the key in order to improve the quality of care at your hospital. At the Mass General Hospital, we were fortunate enough to start with the NSQIP when it first started, before the American College of Surgeons had started into it. That was with the VA and its architect, Shukri Khoury. And he called it the National Surgical Quality Improvement Program. Quality improvement, and that's what it's been all about. And that's high quality data. So the partners hospitals have been part of the first 5 out of the 17 hospitals who were involved in this NSQIP. And we were all very excited when we first wanted to get our information to figure out how well we're doing because we are the MGH. We are the man's greatest hospital. So we got our risk-adjusted, prospective, standardized definition from audited, trained nurse reviewers, nurses like Linda Burr, who's out there in the audience, who goes and looks at the charts and calls the patients if the data is not there at 30 days to have the high-quality data that we trust. So when we get our first risk-adjusted report, where was man's greatest hospital? Right in the middle. Right in the middle. That's not where we expected ourselves to be, but that means that we need to improve the quality of care. And so we've tried to do that. We've tried to look at the data, find out where the problems are, and use that data to drive the quality improvement progress. One of the things we found out was that we had a very high urinary tract infection rate. We wouldn't have known. It's hard to motivate surgeons around urinary tract infections. Anastomotic leaks, we care a lot about those. But UTIs, they do cause a lot of harm. They do cause a lot of costs, and they do cause a lot of harm to our patients when they suffer from them. So when we identified this, we drilled upon them. We figured out the best practices. We instituted those. Our rates went from 7%, which was well above the national average, to 1.9% in 1 year. And we wouldn't have known about this without the data. But it's continuous quality improvement. So the next year, we were 1.8. We're pretty happy about that. We kind of didn't focus on it. 2%. And the next year, 3%. Started creeping up. Continuous quality improvement. We were continuously measuring it. And so when we started creeping up, we identified it again. Focused on it, boom, right back down. So that's what high quality data can do. It can focus on the things that you might not even think are important, but they are. They do cause harm. And you can improve upon them when you focus on them. So we've been focusing on that not only at the MGH, but at the other partners institutions. We've worked collaboratively with the Brigham, North Shore, and other groups in the partners group in order to focus on this. It's been the focus for our pay for performance. We've had pay for performance contracts through Blue Cross Blue Shield and other payers, and we've focused on specific types of procedures that we could improve upon. And did we? We did. When we focused on colectomies at the MGH, we reduced our complication rates the next year by about 50%. And that's not all. It's not decreasing the complications. Well, that's better for the patients, and it's what we want to do. It also decreased costs. In fact, at the North Shore, when they looked at it, they realized that all the surgeons were providing similar high quality of care. And then they could focus on the costs. And they found out the providers who were creating the lowest costs and shared the best practices around costs. And they decreased their costs by 20% in 1 year, just on those procedures, the colectomy procedures. So by having high quality data, you can look at it. You can drive your quality improvement, and you can decrease the cost of care at our institutions and across the collaboratives that we've worked with. There's a collaborative now with the partners hospitals. There's a bariatric surgery collaborative around the partners hospitals. And many of you have gotten this email already, but there soon will be a statewide collaborative around NSQIP by the Mass State Chapter, Dr. Mark Rubin spearheading that. So I hope that everybody's involved with that as that kicks off this summer. So I just want to give a little highlight about what this has been for us at the MGH, focus on the high quality data in order to improve the quality of care that we provide. Thank you.
So in the limited time, I want to make a couple of points or reflections on the discussion of quality. The first one is that the problem of bad quality is actually a lot worse than we think. It's very easy to see that bad quality hurts patients and it costs a lot, but it goes beyond that. And one of the illustrative examples that I'd like to give is a recent experience that I had visiting an ICU in Tanzania. Part of the work of the Center for Surgery and Public Health, it's mostly about health services research and policy related to the U.S., but we also have a division that works in global health. And I was visiting this ICU, and the ICU that I was visiting was in a hospital in Dar es Salaam. It had 8 ICU beds, and they were serving a population of about 8 million, so 8 hospital beds, 8 ICU beds for 8 million people. I noticed that there was somebody in the back that looked like he was in really bad shape, and I asked the doctor about it, who's this fellow in the back? He says, oh, he has tetanus. Now, I don't see a lot of tetanus. I imagine you guys don't see a whole lot of tetanus either. And so I asked, well, what's his chance of surviving? And they said, well, 90%. And his buddy whacks him and says, 90%? What are you talking about? 100%. He's not going to live. They never live. And so that was sort of curious to see that this 12% of their ICU beds for 8 million people was being occupied by somebody who wasn't going to live. And it made me think not so much about, well, we should never send people with tetanus to ICU. It made me think more about, what I do, general surgery. And when my patients have complications, they use capacity, they use resources. Now, in Tanzania, it's very easy to see that there's a ceiling on costs. They can't go much higher. They can't afford to have more than 8 ICU beds serving the city of Dar es Salaam. And yet we act as if there's no ceiling, but there is. There is a ceiling. There's limited resources that we can actually use. And when there's limited resources, the only way to expand your resources is to get more benefit out of your dollar, which is all about improving quality. Whenever I have a complication, somebody's suffering. It's not just the patient who's suffering. But when my expenses go up for taking care of that patient, because there's constraints on resources, somebody somewhere isn't getting something they need. There may be a nurse's aide who gets laid off. There may be a smoking cessation program that gets cut. And so the problem of bad quality is much bigger than simply the delivery of care to the specific patient or the driving up the cost. The second point I wanted to make is that we really need to spend less time worrying about wrong site surgery and more time thinking about wrong patient surgery. And Professor Altman mentioned this earlier about appropriateness, and that we're doing a lot of surgery, presumably, because in patients who don't really require the surgery or is somehow inappropriate for the operation. Now, there's a long-standing tradition in medicine to try to stop inappropriate things by throwing up blocks and hurdles. And you've all had to deal with paperwork related to insurance pre-approvals and the like. There's all kinds of paperwork. There are all kinds of checks, specialty checks, pre-op visits, things like that, in order to try to stop us from operating on the wrong person. And everybody's had this experience. You see a very old man in your clinic. He needs an operation. You think he needs an operation, but he lands in your office without any medical record. So you order a bunch of tests. You book him for surgery. He goes and sees the anesthesiologist the day before surgery, and the anesthesiologist says, whoa, I don't think I can put you to sleep. You've got a bad heart problem or a lung problem. And so he goes off to see the specialist. The specialist says, okay, well, I think he can tolerate the surgery, sends him back to the anesthesiologist. Meanwhile, the patient's daughter shows up and says, I don't really understand what my father's having done. And they explain the possible complications of anesthesia, and they say, whoa, that's nothing like what we were bargaining for. My father, has a limited do not resuscitate order. We don't want him to undergo the surgery, and it gets canceled. Okay, so there were numerous blocks along the way, the possible stopping this gentleman from having surgery, and eventually it stopped. However, the real problem isn't that people didn't want to do the right thing. It's that there were well-meaning physicians in a system that was broken, fragmented, and needs to be brought together in a way so that the people who need the operations get them, and the people who don't. So, in effect, finally, I believe that the real untapped power within our systems is the desire of surgeons to deliver the right care to the right person. And that right now our approach of trying to block them from operating on the wrong person is the wrong approach. The right approach is to develop systems to make it the absolute easiest thing to do the right thing, and then everybody will take that path of least resistance and end up doing the right thing. So it's systems changes that we need. Thanks.
I'll just add a couple of things. I think the most interesting part about the discussion so far are two things. First is that we know what to do, and that wasn't the case 15 or 20 years ago. We now know that we have approaches to try to align the payments so that when people are pursuing better quality and lower costs, they aren't penalized for it. We don't exactly have the recipe, but we now have, especially in this state, we're moving very quickly to trying out new payment mechanisms that move in those directions, and that's part of what Stuart Altman talked about. We've also recognized that we have to be able to measure the results. And part of the story here is the idea that electronic health record systems are going to be able to provide enough information to tell us where all the quality and cost issues are belied by the fact that you need incredible detailed knowledge, the kind of knowledge that Matt started talking about, which is why registries like NSQIP that tell you about the specific kinds of issues that surgical patients have, or the specific kinds of issues that cardiology patients have, or the specific kinds of issues that childbirth patients have, give you a lot more about the nuance of why some places are better than others. We've learned that the places that are better than others are not the most expensive in the country. They're among the least expensive. And what that's led us to is starting to try to recognize what they are doing differently when they are positive deviants, what the innovations are that let them be better, what has allowed the place that was at the top of that urinary tract infection curve to do better than others. And we're discovering they're often simple things. A checklist was probably the core part of it, the Johns Hopkins checklist for reducing urinary tract infections. We've discovered ways to use similar approaches to reduce complications in the operating room, in surgery, and beyond. Where we're struggling is with how to begin to implement and package all of this together so that it happens at large scale. What we're starting to see are some large health systems that are moving faster, moving farther, and I think are going to show that it is quite possible to make remarkable progress over the next few years. The great fear that I think many of us have, and the American College of Surgeons has, is that others will be left behind. When American College of Surgeons created the trauma system nationally, it was out of recognition that there were some great trauma centers all around the country. But if you wanted to make sure that this reached an entire population where you could be in Nebraska, in the western part of Massachusetts, in California, anywhere, that you would get sound trauma care. A lot of the work that we've been doing in some of our centers includes work to try to bring the work we're doing to other populations. So work that came out of Boston that recognized that a checklist for basic aspects of surgical care could reduce deaths and complications by more than a third has not penetrated to other parts of the country. And so we started a project combining measurement at a state level in the state of South Carolina in partnership with the South Carolina Hospital Association to bring the surgical checklist to every hospital in the state, all across the entire board. And over the last year, we've succeeded in bringing it to 60% of the patients in the state. We believe we'll be able to close it to over 90% of the patients in the state, and then be able to have the measures that, that a number of people here talked about that allow you to see whether infections and deaths actually drop at a population level. That's the prospect, I think, of what's to come, being able to change the entire result at a statewide level, be able to incorporate into our registries measures of the costs so that we know whether the costs are also improving. And then the last thing that I think is really striking and remarkable here, and a huge difference from 2 decades ago, is this, the physician leadership that we're seeing across the way, where mostly we as physicians had been fairly defensive about the kinds of changes that were coming in the 1980s and 1990s. I think this is the first opportunity we've recognized that the systems are changing in ways that would allow us to be innovative in the work that we do. If we understand, here is your opportunity, here's where your organization stands in complications and in costs and in outcomes for patients. And then here are the opportunities to devise solutions that not only can change your system, but then can be brought to lots of places across an entire country. Thanks.
Good afternoon, everyone. My name is Peter Slavin, and I guess I was invited as the token internist here among this very distinguished group of surgeons. But more seriously, I want to congratulate the surgeons here with me and the American College for taking such a leadership role in the area of quality. I think if you look across all the specialty organizations in this country, I don't think anyone has sort of carved out this niche as effectively and with as much vigor as the American College of Surgery, and so I just want to congratulate you and your specialty for doing just that. I wanted to underscore 1 or 2 points that were made and then make a couple of others. I want to underscore the sense of urgency that I think Stuart mentioned in his talk. I think the economic pressures facing this country really force us to act with a great sense of urgency and purpose. As we sit here today, 40% of all of our federal spending in this country is being financed through debt, and we can afford that for some period of time, but we can't afford it for a long time. And as Stuart showed, if you just straight line the impact that Medicare and Medicaid are going to have on federal spending and on the economy as a whole, we need to do something desperately to bend the cost curve. The cost of health care as we sit here today is also forcing major trade-offs at level of government, businesses, families, and individuals, and I think it's because of some of those trade-offs that we also need to act with a great sense of urgency. I don't particularly like Microsoft products, but I do like a quote from Bill Gates from about a year ago, and I'm paraphrasing, but he said that how many teachers are we going to lay off in this country to be able to afford procedures on the elderly that provide them with either no value or very marginal value? As we sit here today, those trade-offs are being made by cities and towns across this country, and I think we bear some responsibility to make sure that the societal resources that we employ in healthcare are just as much as our patients need, but no more and no less. Like I said, I'm very excited, bullish about the NSQIP as it's been applied at MGH and across this country. I'm also very excited about the bundled payment initiatives that Stuart mentioned, but I think we need to be even more ambitious. Not only do we need to control the quality and cost of individual units of care that we deliver to patients, but we also need to do something dramatically about the utilization rates of services as well. Ever since Jack Wemberg published his landmark articles about the variation in care delivered across this country, we as a society, as a profession, and as an industry have really never adequately, in my mind, addressed that. Some of it is obviously explained by poverty and teaching density in various municipalities and states, but a lot of it is unexplained, and I think we need to do a much better job getting our hands around issues of utilization and appropriateness than we have up until now. And NSQIP and bundled payments don't really address that, and I'm excited to hear that maybe that the American College of Surgeons is working on trying to expand NSQIP in the future. Now, as a hospital president, I can't tell surgeons how to practice surgery or psychiatrists how to practice psychiatry, but I think there are some things at an institutional level that we can do to try to move this agenda along. One is simply to provide some leadership, and by leadership, looking for every opportunity to underscore the fact that there's no more important job that we have these days than making healthcare better and more affordable, and allocating resources within the institution along those lines, and and using all forms of communication, be it meeting agendas, written communication that goes across the organization to repeatedly reinforce that message. Second thing that we can do is build the infrastructure necessary to advance this work. You can have very well-motivated surgeons and internists who are interested in this, but unless they have access to information, unless they have access to project management support, and unless they have access to expertise and process improvement, all that goodwill and good best of intentions isn't going to go very far. So we as institutional leaders have a responsibility to make sure that we have adequate amounts of that infrastructure. And then the third thing that we can do, and I'm sure there's a long list of things that we can do, but I just wanted to mention three, is to provide the necessary incentives for this work also to be taken very seriously and for people to focus on it. I don't think incentives are critical to doing this. I think you can probably get by without them, but I've certainly seen at MGH a couple of incentive programs that have had a very significant impact. Several years ago, our physicians organization implemented a quality incentive program that gave every physician in the institution an opportunity to earn $5,000 a year based on the progress we made on institutional quality goals and also departmental quality goals. And I think the progress we've made, I think, has been significantly enhanced by an incentive that is a very small percentage of each physician's income. We also have implemented an executive incentive plan related to quality and patient safety that, again, is a very small percentage of executive compensation, but I think has provided needed focus. I think one of the biggest intellectual challenges that we face in the coming years is how do we create the right incentive systems under global payments and capitation? How do you incent physicians? How do you incent surgeons to provide just the right amounts of surgery, but also be productive at the same time? And it's going to take years before we figure out how to migrate our compensation systems from the heavily productivity-oriented systems that are now in place that certainly help make the fee-for-service reimbursement system work well. So those are just a few thoughts I wanted to share about what, at an institutional level, I think people like myself can do to perhaps help move this agenda along.
Thank you. Thank you. Thank you, guys. Andy?
Well, we theoretically have the job of summarizing what has just been said, so you heard it, that's it. We do want to save time for questions, and there will be microphones being passed around. We do hope that you will take advantage of this really quite impressive panel, each of whom has given you a very different point of view, but there are lots of gaps between the different presentations. Please make your questions succinct. They shouldn't be additional papers that you're presenting, but be based on a question. And we have paintballs that we can fire at people who talk too long. Let me start this while the microphones are being passed around. You can think about your question. I'm going to go back to my president, Peter Slavin. I got to tell you that Peter starts every General Executive Committee meeting with a quality and safety moment, if you will, something that's going on in the hospital. At the same time, there are dozens, even hundreds of quality issues, whether it's issues from the National Quality Foundation or others. Everybody's converging on the things that you've got to do to make quality. Peter, what advice do you have to avoid quality and safety fatigue, that we can get people engaged in this without feeling bombarded and turned off?
Andy, I wish I had an easy answer to that question. I think one of the problems that we face as an industry and as a profession is that because we haven't been as proactive as perhaps we should have been over recent decades, others have taken the lead in trying to define what it is that we do. So you're absolutely right. A significant proportion of our quality agenda at MGH and across this country is reactive to the requirements of the Joint Commission, reactive to the requirements of our State Department of Public Health. There is a Tower of Babel that we have to produce in terms of quality measures to satisfy the different organizations out there that are interested in quality in some way, shape, or form. Despite that, we have to make progress within our organizations toward actually improving quality, and so we need to use our different the sensory components of our quality management systems within our organizations to identify the quality issues that are the most important and make sure that we apply the resources and the focus to making those issues better. So I wish we could make that Tower of Babel go away, but we can't, and so we have to make progress despite it.
Let me open this up. I suspect that there are a number of individuals in the audience who might have questions. What we'd like you to do, though, is to identify yourself and what institution or what program you're associated with.
I'm Keith Golmo from the MGH, the Department of Surgery. I'd like to direct this question to Dr. Altman because I was very impressed that he mentioned the value and the importance of the academic health center in the future. I guess I would say the academic health centers have the target on their back as being high cost without measurable improvements in quality being able to be demonstrated, but yet we have our research mission, our education mission, as well as taking care of usually the most complicated and sick patients in the system. So what would you advise those of us at academic health centers of how we should participate at the highest level? Again, you heard a lot of the things going on at the institutions, but what can we do that really will affect those people at Beacon Hill or Washington to get the same view that you have, that academic health centers are important?
Well, I don't want to pander to you, but I am part of the academic medical center sort of hierarchy in a lot of ways. And I have been a very supporter for a long time. But I will tell you this, the one thing that really set me back, it set me back in the 70s, and I just recently heard it again. And you didn't say it, so I don't want to pin you down. And I'm going to be extreme for sake of the point. I've heard it from pretty high-level people say, look, our job in academic medicine is first to train the next generation of physicians, and second to do cutting research and so on and so forth, and third, and a far distant third, is patient care. And I tell you, you say, and many of you would be horrified, but I've heard that more than once. That does not sit well. These three things have to be simultaneously of equal importance. If you're not going to be the leaders in the kind of stuff you were talking about, generating the data, finding the place where the data makes a difference, developing the safety standards, who is going to be the leader? You know, Atul, said, and he's right, but it's a little scary that often there are times when we find the leaders are not among academic medicine. I find that unfortunate. Not only are you are the best and the brightest that we have, and if you're not going to lead us, I don't know where the true leaders. Sure, we're going to find isolated cases in places like that, but you have to be the leaders. And to do that, patient care has to be every bit as important, if not the most important, of those three goals. I'm not saying in any way you should cut back on research or education, but please do not make patient care a distant third.
So how do we convince the legislatures, the insurers, the people who are going to steer patients away from the academic centers because they're more expensive, that what we're doing is God's work?
Well, two things. First of all, this idea that you have, we don't need to send every patient to an academic health center, and some academic health centers have developed perhaps sort of a reach which is larger than needed. But for the patients, now I understand the need for balance, so, and the need to have all different kind of patients, but there are patients that don't need to be in the academic health center. And I think the quicker you're on the side of them for that purpose, look, I think half of that is baloney. When all gets said and done, the payer mix and the policy are really not going to attack you nearly as much as they say they are. But you need to meet them halfway, and then they'll back off. And that is, let's be clear, regionalization, so that you have within your mix, and I don't want partners is doing that. So you develop community hospitals that are part of the mix, so the patients that don't need to be in the Brigham or the Mass General don't go there. Second, that you do stop the patients that don't need to have the surgery quicker than the example you gave. That was an unnecessary. That should have been the first question you asked, with that, why that elderly person was getting that surgery, rather than the last. So if you meet them halfway, my sense is that the pressure from the policy community and the payer community will back away.
Let any other on the panelists want to comment on this? This is, obviously, we're in Boston. Every other block has a teaching hospital. We have a high percentage of care delivered at teaching hospitals. So, Dr. Slavin.
Well, I guess I think one other thing we need to do is to clearly explain to members of the legislature, both here and in Washington, why teaching hospitals are more expensive. There's not great data on the subject, but I think the best data suggests that the actual direct cost of the care between community hospitals and teaching hospitals is not significantly different. Why teaching hospitals are about 30% more expensive than community hospitals is because we have to recover the losses associated with research from our clinical care, the losses associated with education from our clinical care, the losses associated with caring for a disproportionate share of poor people, and the losses associated with some very specialized services that we provide, like transplant units or burn units, whose patients can't come close to covering the costs. I wish all those things were paid separate from the reimbursement system so we could compete more effectively on price with community hospitals, but because of those public goods that we provide that whose costs get layered into our clinical costs, we can't. But I think it's important when legislators advocate for moving patients from teaching hospitals to community hospitals, what they're really saying is we want less research, less education, less care of the poor people, and less specialized services in this community, because that's the impact that it will have.
Question, there was a question over there.
David Robertson from Children's. So 100 people come into me today and I recommend surgery for 70, I'll make more money. We can imagine some new fantasy system 15 years from now where I'm really innovative and I come up with great medical treatments and only 30 of them need surgery and I get to share in I get paid for being smarter. But under the current system, I would lose a lot of money. And it's hard enough to imagine this new fantasy system 20 years from now, but how do you imagine migrating from system A to system B without all of us undergoing, if every surgeon in the country is going to undergo personal financial disruption, that's going to be a big pushback. And let's be honest, people are afraid of that. How do you imagine migrating from point A to point B?
Who'd like to take that one?
Good. Partly, I'd say by watching what actually already is happening. So the Bureau of Labor Statistics came out with its results last quarter showing that 88% of physicians are now no longer self-employed, that we have, especially in the last 5 years, signed up to join organizations where compensations are changing rapidly. And you're seeing growth of changes like going on to salaries plus bonuses of various kinds related to quality and other kinds of outcomes. And as systems move to bundled payments where you're saying that for the 90 days of a patient with a particular condition, that all of the services that come together fit into there, that all of the ways in which you describe being compensated today start breaking down when you want to get everybody on the same team, the radiologists, the primary care, the surgeons, and so on. And so the pressure that's moving very quickly has been towards, first of all, having people's practices come under one roof, and then within those practices starting to change the compensation mechanisms radically. And I would predict that we will have a large surge in salaries being the way that we move, and it won't be in 15 years. It'll be very soon.
Well, let me add one more. We had the experience in managed care. I was in Los Angeles from 1988 to 1994. We had the experience in managed care where, as Dr. Altman mentioned, the profits came out of the system and didn't go back in to reinvest. The profits went other places. Mm-hmm. The systems that we're talking about now, accountable care organizations, bundled payments, they're going to be reinvested. That's the notion of shared savings. That's a dramatic difference than what we were talking about 15 or 20 years ago. And, who can predict the future? But I think that opportunity exists for us to share. Where I have trouble is knowing where that tipping point is, going from the current fee-for-service environment to that kind of environment, and not having a foot in two boats, which is going to be the hard part. And, it's going to take some work to get there.
I might add that, this represents a fundamental tension, something that I noticed long ago when I was at Dartmouth, where arguably ACOs were invented. I would go and teach at the Dartmouth Institute for Healthcare Policy, and then I would go back across the street to Dartmouth Hitchcock, where I would practice and have all of my RVUs very carefully counted, and my salary based on how many RVUs I produced, which is a fundamental conflict. The approach of fee for service, which is incentivizing the more you do, the better, and the ACO concept, which is rewarding the most parsimonious and appropriate high-quality care possible. And I think it's inevitable that as bundled payments roll out, that this tension will come to a head. And I don't think the ACOs are going to change unless the Supreme Court has other thoughts. But I think that what will change is what Atul was talking about, is that we gradually will see this wave of changes in the way that individual physicians are reimbursed.
Let me be less subtle than I was in my speech. The reason why we want you as part of the solution, not the problem, is we threw out managed care and capitation too quickly, and it took a decade of 15 years where we're trying to sort of restructure it and redo it again. And what Mike's saying is so important. Capitation changes the nature of the debate so that you can benefit from the savings, that you are not the total loser of doing less of the most complicated stuff. And the key is what he said, is that a portion of the savings, maybe not all of them, need to be redirected back into the system to reward the people who are involved. You very much, you collectively destroyed managed care. And I understand why you did it. I hope that you don't destroy the new version, but you make it work better so that you are part of the solution. But what you answered is, we will not solve this problem unless we change the payment system.
There's a question over here.
I'm Jerry Doherty from Boston Medical Center. I've enjoyed the panel today. I think so far we've kind of done the easy stuff with NSQIP and the various quality collaboratives around the country, because nobody wants central line infections or urinary tract infections. Everybody's on board going in the same direction. The next step is the hard stuff, as we've just heard, because it'll affect the way we get paid and how much work we do. In order to change the cost curve, we actually have to do less. The math doesn't work unless we do fewer procedures and spend less doing it. So back to Dr. Codman's plan that we can only change what we measure, does the college have a plan to measure appropriateness of procedures? Do we have a way to start going to look and see whether that patient should have had a coronary artery bypass or a PCI, or should this person have had a hip implant and so on? Can the college help us to get there?
If I may, just to paraphrase a bit your question, which is right smack on the mark, when we talk about quality, we're going to run out of the easy things like urinary tract infections for continuous quality improvement. And quality is now going to be defined, as Dr. Altman said, about the things that should be done or shouldn't be done. And that's where ultimately this is going to go. How do we get there? Matt, you've been involved in that.
We don't know. I mean, it is a big challenge, to be honest. Working closely with Research in Optimal Patient Care, which is the committee through the American College of Surgeons, this is first and foremost on everybody's mind, about how to take something like the ACS NSQIP and develop it for appropriateness. But we don't know how to do that. We don't know how to do that in our own M&M conference, let alone at a society level. Society has to decide this before we can tell them what to do. We can't say, oh no, we as surgeons have decided that your grandma doesn't need an operation. Society has to work with us, when we can hopefully work with society in order to make these changes, and they don't happen overnight. So this is going to be an uphill battle, and we're thinking about how we can do it, and we don't have answers right now.
Atul?
Just a couple things before we throw out the idea, though, that how much gain comes from the first point, which is care that is not actually valuable, is harmful, is costly, and that you see the major downstream consequences. When you look at the 5% who account for 50% of healthcare costs, and especially the 1% who account for about 30% of healthcare costs, these are groups of people who are very poorly cared for in the system, have many broken lines of care, and the places that do best and achieve better results are the places that are able to tackle those problems. And so one of my sort of orientation questions would be that I'm not sure that the question you raised is the right measure to have at the national level or even at a local level. That question being, should you have done that particular operation? Instead, I think it's the value metric. Can you tell people what the outcomes and success measures are and what the costs were so that you can begin to describe to places where they stand on that value curve? If you look at total knee replacement, for example, between places it's a $25,000 to $140,000 procedure, but those don't have any strong relationship with the outcomes whatsoever. And there are important questions about the patient who cannot rehab at all, but from the numbers, the big value comes from reducing that wasted increment, which is a large amount when you start seeing that there are places in the bottom half of the cost curve getting top quartile results. So I'm not quite ready to say there isn't huge gain to be gotten in the next decade from concentrating on those other portions.
Questions over here? I see. Gary. Mike.
Dr. Gottlieb?
Hi, Gary Gottlieb, Partners. Stuart, part of the elegance of the juxtaposition of the ACO and the bundle payment is that it does away with the polarity that we created with the purely managed, cost-managed care environment, where we basically had so much of the risk sitting in primary care physicians. We polarized primary care physicians from institutions and from specialists. And part of the challenge of softening and essentially creating a shared set of interests is to be able to allow both sets of organizations and individuals to have skin in the game, which is what bundles would do for the most frequent episodes in a system that was taking risk, even if it was sharing that risk along a broader ACO. One of the challenges in each of the great ideas that you had was softness of implementation and partial implementation. And one of the challenges we saw, for example, in the CMMI bundle proposal is that the DRGs stay fixed as hospital DRGs without essentially creating fungibility across the whole episode, which is where the creativity needs to come from. That if, in fact, an episode is going to essentially cost X amount of dollars and a physician is going to really have skin in the game and be able to warranty that care over a period of time, all of the dollars that are in the episode need to be available as opposed to having fixed dollops. And speak to the notion of kind of doing it in a conservative way and whether that will undermine us in the way that it did before.
So, I want to go back to your discussion of Dr. Codman. When we think about the real pioneers of any area, these are not, by and large, people who are mellow and quiet and do things in moderation. They believe that they have truth on their side, and they do just what maybe now, after 40 years of having been beaten up. So I used to be 6'4" when I started as the regulator there. So, and I was one of those people. I mean, I really believed in every one of those things, and there was no moderation. But I'm now coming around to your point of view, including, I mean, you know, your friends up in Dartmouth. I mean, there's no ifs, ands, or buts with that group. I mean, they know the truth. So, yeah, I mean, I do believe now that we need to move forward on a variety of fronts. We need to do it in ways that push the ball forward, but to do it in a way that doesn't create more enemies than it solves. And that's what happened in managed care, big time. You know, that's what I was trying to say before. The fact that you became our enemy, or became their enemy, you're too powerful. And when I say you, I'm talking about the collectives of the specialists, the collectives of, I don't want to be on a battlefield where all the teaching hospitals are on the other side. That's not a battle I want to be part of, nor is it the battle I think is going to win. So yes, I do believe we need to do this in moderation, but we need to do it. And we need to move forward in incremental steps and make it work while we allow, you know, what Atul said is so right. We need those pioneers out there to show us the way, but ultimately the majority of us are going to come along more slowly. But, you know, and I hope we have time.
There's a question there, and there's a question there.
We got
Hi, Joel Weissman from the Center for Surgery and Public Health. Stuart, many years ago when I took classes with you, you used to talk about the healthcare system as a giant balloon, and if you pressed on one part of it to try and control costs, it would just expand someplace else. I know you haven't been exactly rosy in optimism, but I'm wondering if maybe even now you're being optimistic about the ability of the healthcare system, ACOs, bundled payment, to control costs. From what I understand, ACOs, mostly for Medicare patients, what healthcare systems are talking about doing is backfilling with better payers. With bundled payments, you can control the cost with a bundle, but you can't control the number of bundles. And I guess when you're answering that, I also want you to think about one of the possible repercussions. In an article in the New York Times this weekend, they talked about major employers now moving to extremely high deductible health plans, $5,000, $7,000 for deductibles for families. So the question is, does your metaphor of the balloon still hold? And if yes, are we going to find some of the effects on the backs of consumers and patients?
So the last slide, I put it on purpose. I do not see ACOs, bundled payments, or this movement as the end of the game. At some point, we're going to have to put healthcare on some form of a budget. I think the budget ought to be moderate. I don't think we ought to assume that we're going to move to these numbers that are being thrown out as GDP minus 2%. But I do believe we do need to think about putting total healthcare spending into some overall budget so that we don't do what you said. And I don't see that happening. What I see happening is that particularly our big payers are going to be on a budget. Medicare will be on a budget, Medicaid will be on a budget. Everyone's going to be running towards the private sector to continue to cost shift more and more. And that's where we're going to do just what you said, and that is that the private sector, trying to protect itself, is just going to continue to under-insure its patients. And so you're going to wind up with huge bad debts, because these people are not going to be able to afford the $10,000 and the $15,000. So yes, this is not the end of the game. This is a more serious problem, and but it's the beginning. It's moving in the right direction, and we can't solve all the problems right away. We need to get the quality out. We can make a lot of savings, but you know, there's going to be I haven't talked about what's really pushing healthcare costs, and it's prices. It's not volume. And getting at prices is very hard, because a lot of it is not in the healthcare. It's the amount we pay for drugs and so on and so forth. But that's another meeting.
Nancy, I saw a couple of, yeah.
This is just a follow-up on Dr. Gawande's comments about the lack of correlation between quality and price, or quality and cost in the system. And it's really a question for Stuart. Dr. Altman, if you would predict, do you think that the government is going to set rates so that a hip replacement at Tufts Medical Center is the same as a hip replacement at the Mass General in terms of total cost? Could you just address that? Because I think there's a lot of the market forces that go into these costs that are not necessarily related to quality.
Well, first of all, the government's already setting rates. What's happening, so, you are getting a DRG payment for the part that you're
I mean for private insurers.
all right, so now that's what I was going to get at. So, first of all, if you look at the numbers, forget about anything. If you just look at the demographics, you go out 20 years from now, the government payers with I'm not even talking about healthcare reform, the existing structure, the average hospital will get between 60 and 80% of its revenue from the government. So we don't have to set rates for the private sector. You're going to be on a rate-setting system without the government coming in and setting private rates. But it's what I said is going to happen. Everyone is going to try to run, first of all, change your payer mix. I mean, I heard a terrible story, which I'm not going to recite, by a teaching hospital that was just determined to change its payer mix in favor of private. There's just so much you can do there. So ultimately, I do think you're going to need to control your total costs, regardless of whether the government sets private rates. I think you may want the government at some point to set all the rates and pay you fairly. I mean, I don't want to see American healthcare a gigantic mesh system. That would be the worst. That's why I said I don't want to see that, but I do see that as a possible option when we hit 25% of GDP.
I think we have time for one more question there, and then I'm going to have a question, and then I think Andy and I need to summarize.
I just wanted to make a comment, and I think that everyone wants to improve quality care economically. And all hospitals, regardless of size, if they focus initially, perhaps using a quality tool to discover some of the outstanding problems that they're having in their hospital, if they form teams within their hospital, utilizing all of the different services and sitting down together to discuss how each of them contribute to making that aspect of care better, whether it's dietary, respiratory care, infectious disease, nursing, whatever. Everybody plays a part in that. And so all hospitals, regardless of size, if they sit down together as a team and identify their problem and then try to figure out how each department can contribute to improving that, it's something that all hospitals can do without any great outlay of money. And I know that one thing that we did at our hospital was to start rounding. I think a lot of hospitals focus on the 7 to 3 shift, and they don't realize that there's 16 more hours of patient care. And lots of times the people who work on the evening and night shifts have a limited idea of what the goal of care for the 24 hours is. And so I used to be a critical care nurse, and we started having rounds and evenings so that, and the whole team met, the intensivist, the respiratory therapist, physical therapy, nursing, we all, and the interns and residents who were covering the patients, and would discuss what the goal was going to be for the next 16 hours to get the patient through the morning. So I think that there's an opportunity for everybody to try to improve if they just work with what they already have.
Thank you. Stuart, I'm going to take advantage of you being here, and I'm going to go a little off the track a little bit. In a few weeks, we're going to hear from the Supreme Court. We're going to know one way or the other whether a portion of the Affordable Care Act or all of it will be struck down. in either of those circumstances, what's Plan B?
Well, I want to be very objective. From my point of view, that would be a lose-lose-lose situation. And I think the biggest losers, other than the fact that the people that are now insured is going to be the healthcare system. The cost problems are not going to go away. Clearly, the quality problems you're going to have to deal with. I think this movement towards redesigned delivery system is independent of that. I think that what you're talking about today is totally independent of it. The reason why I think it would be terribly unfortunate is that the environment in which you're going to be operating is going to be in a much more crisis mode. But what we're talking about today is independent of those calls. Everything you've said today, from the academy's point, from the college's point of view, from all the speakers, is not related alone to what's going on there. But as I said, from my perspective, the lack of resources that you're going to be operating with, and the pressure, as I said, just take one number, the trust fund will be in crisis almost immediately. It'll shoot down to 2017, and you know they're going to panic. You know, once they realize, all the rhetoric notwithstanding, the people that want to end it are going to be the ones that are going to have to help deal with it. So, again, what we're talking about today is independent of the call.
Thank you. Andy, some summary comments?
I think it's, first of all, I just simply want to thank the panelists. I think this has been an outstanding presentation. Multiple different points of view, but you all converged on the issues. And I think the summary is there are a lot of ideas, but we have a lot of work to do to make them come true. I think we need to define quality. We need to define appropriateness. We need to have mechanisms for investigating those and validating them, following the 4 principles of the college as outlined here. So this is just the beginning. We've got a lot of work to do.
I, too, would like to thank the panelists. I know you've taken some time out of your day. I want to thank the audience, too, for time out of your day. These are important issues. I particularly want to thank Nancy Longley, who's really helped organize this over months. A couple of takeaway themes for me. There are some consistent themes. They center around data, real data we believe in, innovation, things that you've heard about today, systemness, things we never talked about before. And if we put all of those together, we're going to improve care, improve quality, improve access, and lower cost. And with that, we'll call it an evening. Thank you.